because it seems to. Okay. All right. Well, welcome everybody to pediatric teaching today. I mean, I'm in Port Moresby today, and I wanted to talk about just the management of some common cases of critical illness in children. And I think they're very common conditions, but several of them have uncommon characteristics or characteristics that you might not typically recognize. And I just want to go through some of these characteristics and see if we can recognize some other aspects of critical illness. So it would be good if it was fairly silent in the room, but let's go from here. All right, the first case, this is a 13-month-old boy who had 2 days of cough, fever, and respiratory distress. He had a respiratory rate of 70 and had severe chest indrawing. His heart rate was 170 and his oxygen saturation was 82. Now, he had a very prolonged expiratory phase and lots of wheeze and lots of crackles. And what do you think's going on when you look at his X-ray? Can someone tell me what you think the problem might be? So 13 months old, 2 days of cough, fever, and respiratory distress. He's got very prolonged expiratory phase to his breathing. When I say prolonged expiratory phase, I hope you understand that normally when we breathe in and when we breathe out, is that an equal amount of time do we spend breathing in and out, or is not an equal amount? No, it's not quite an equal amount. What is it, Mane?
It's more longer when people
Yeah, that's right. It's more longer when we're breathing in and a bit less time when we're breathing out. Why is that? Yeah, what's that? Yeah, that's right. We're using our muscles to contract. Our muscles have to contract, the diaphragm contracts. So we use our muscles to breathe in. And when we breathe out, what are we using? Usually we're using just
a diaphragm.
Sorry? It's just elastic recoil of the lungs, isn't it? It's just, there's no force required. But in some children, you notice that they have a very prolonged expiratory phase. So their breathing in might be half a second and their breathing out might be a second and a half. All right, a prolonged expiratory phase. And in those circumstances, if you watch them, they're using their muscles to breathe out. Right? They're having to actively breathe out, not just elastic recoil of their lungs like we normally do. They're using their muscles to breathe out, right? And so what children have a very prolonged expiratory phase and need to use their muscles to breathe out? Yeah, children with bronchiolitis, children who've got any form of airflow obstruction, if they've got expiratory airflow obstruction for any reason, whether it's bronchiolitis or it's severe asthma, then you need to use your muscles to breathe out because there's some obstruction to flow. So that's why you put extra force against the expiratory phase, right? And that's why it takes longer. All right. So next time you see a child who's got bronchiolitis or got asthma, just look at their expiratory phase and see how long that is. Right. And you can time their inspiration and expiration, and you can see that. So this child had both a prolonged expiratory phase and also wheeze, so consistent with expiratory airflow obstruction. All right, usually that wheeze is expiratory, but sometimes it can be inspiratory as well as expiratory, but it's almost always expiratory, isn't it? If you hear an inspiratory wheeze, that usually means a different thing. If they've only got an inspiratory wheeze, then you're worried that they've got some upper airway obstruction, right? If all you hear is an expiratory wheeze, then it's likely to be lower airways disease, the bronchi or the bronchioles, right? So, but this child also had crackles. When you look at the child's chest X-ray, what do you see? That's right, hyperinflated lung fields. The diaphragms look flat, don't they? Normally the diaphragms are domed, but they're actually looking flat. What else is it about the lung fields that you can see? Do they look?
Straighten.
I'm sorry, say that again.
The ribs was horizontal.
That's right. The ribs are horizontal. In fact, they look separated and horizontal, don't they? Yeah. And sometimes you'll see that in very hyperinflated lung fields because the ribs are more separated than they normally are because the child's had to take a very deep breath in. That's very good. So there's the diaphragm, the hemidiaphragms are flat. The ribs are more separated. And what about the lung fields themselves? Sometimes we look at lungs and we say, well, these are plethoric lungs, like they're a bit white, yeah? Like they could be plethoric or they could have some increased vascular markings or increased lung markings because of atelectasis or consolidation. What do these lungs look like? They're very black, aren't they? They're very black lung fields. And what does that tell you? When there's black, there is air. So that means the lungs are full of air. It just goes along with there being some expiratory airflow obstruction because there's so much air within the lungs. So this sort of X-ray is characteristic of a child who's got what? Asthma or bronchiolitis, isn't it? Anything that causes like gas trapping in the lungs and expiratory airflow obstruction, right? So I just wanted you to put together those clinical features with those X-ray findings and understand the pathophysiology that's going on and understand why you see the clinical features that you do, especially the expiratory airflow obstruction. All right. In all children that you look after, even those that are critically ill, then the stages of management are just the same. You need to do triage. If you find an emergency sign, give some emergency treatment, then take a proper history and do an examination, then decide whether any laboratory investigations are required, like an X-ray or a blood gas or electrolytes or a full blood count, and then come up with the main diagnosis and then other possible diagnoses. So in this case, what would be your main diagnosis? Bronchiolitis, that would be the main diagnosis. And then with a child who's 13 months with bronchiolitis, what's the supplemental question you have to ask? Like, yes, they've got bronchiolitis because all the features are like that, but what's the other question that you can ask in a child with severe bronchiolitis at 13 months? Well, what's that, Melissa? Yeah, it could be, but also like this child's got severe airflow obstruction, and there's a phase between about 9 months and about 18 months where children might, before 9 months, children with bronchiolitis are a bit different, aren't they? They're not likely to be bronchodilator responsive. They're not likely to be responsive to salbutamol or Atrovent or any of those theophylline, whereas after 9 months they might be, and at 13 months they certainly might be. So this child might have bronchiolitis still might have some bronchodilator responsiveness, right? So that's the question we need to ask, and we need to decide whether or not this child would be responsive to bronchodilators, and it's worth treating this child as if he's got asthma, you see? Yeah, so that's just, in terms of thinking about the differential diagnosis, it could be bronchiolitis with bronchodilator responsiveness, or a bronchiolitis with asthma physiology, or it could just be bronchiolitis. Yeah. Then the treatment, again, that's based on your diagnosis and differential diagnosis, supportive care, monitoring, discharge planning, and follow-up. And if you follow those stages of management in any sick child, you really will have covered all the types of management. So I think you know all this, but I'll just go through it a little bit more. In triage, you need to take a brief history of the presenting problem, take the temperature of the child and weigh the child, and then just go through the ABC. That's simple as that, A, B, C, D. And you,
Johanna, Dr.
that's right. Oh, okay. So you go through the ABC. So it's very simple. And if you get practiced at it within 30 seconds or a minute, you can do the airway, breathing, circulation, and disability. And you can almost do them all at once, but you listen for stridor or obstructed breathing. You look for cyanosis on the lips and the gums and for signs of respiratory distress. that means looking for the degree of chest indrawing and tracheal tug. Remember, if you've got really severe chest indrawing, you'll have chest indrawing where? You can have chest indrawing in 4 places. Where are they? Yeah, subcostal recession, intercostal recession, sternal retraction, and tracheal tug. They're all sorts of chest indrawing, aren't they? So, and if you've got, the more severe it is, the more you have, right? If you've just got a bit of intercostal recession, but no chest indrawing, no subcostal recession, no tracheal tug, then maybe it's mild, yeah? I know you know how to say it's mild, moderate, or severe, but it's good to be able to quantify it, right? To say this child has severe respiratory distress because he has tracheal tug, intercostal recession, subcostal recession, and severe sternal retraction. That's the way you communicate it. Then you check the saturation. You feel the skin and the temperature of the hands and the feet, don't you? And feel the pulse for the pulse volume and the regularity, and check the capillary refill time. And then you assess the child for lethargy and the level of interaction with you as you're examining them. You can do that within a minute or two, definitely, all right? So this child had signs of severe respiratory distress, wasn't it? And had cyanosis. So already you would have decided that the child had emergency signs, and you should stop and you should give treatment. And of course, the emergency treatment you would give in this child would be oxygen, because the saturation was 82. Oxygen is a bronchodilator as well, so very useful, but for the management of asthma, just to relieve the hypoxemia, and also as a bronchodilator. And you might also give some, because the child's 13 months, you might give some salbutamol. You could give a nebulizer of salbutamol in a 13-month-old child, or a meter dose inhaler with spacer if the child was old enough and you had a spacer. And you might decide the child's got severe respiratory distress and has clinical features of an acute lower respiratory tract infection. So you might also give some antibiotics, because it's very hard in this environment to say that a child's just got pure viral bronchiolitis, isn't it? Because many children have both viral and also some secondary bacterial infection, isn't it? And why is that? Why is that? You know, in other countries, it's possible to say, oh, this child's got viral respiratory infection and we won't treat with antibiotics. But PNG, it's much harder. And what's the reason? Sorry? No, not so much. No. Yeah, that's part of the background to it. But what's the practical reason is what they can come late. Yeah. The risk of a I'll just mute. The risk of a secondary a co-infection, risk of co-infection is much higher. And when I say that, the reason for that, does anyone know the reason for it? In some countries, like in Australia, for example, around about 20% maybe of children by the age of 12 months will have like their throat colonized with pneumococcus or Haemophilus. But in PNG, it's been, in the Highlands, it's been recorded as up to 90%. And that usually occurs even in the first month of life. The children get colonized with Haemophilus or pneumococcus in their throat. And so when they get a virus infection, what happens? Yeah, the virus causes some mucosal like inflammation, and then they produce lots of mucus, and then they're coughing a lot, and they're having difficulty swallowing and coughing and have respiratory distress, and they may aspirate some of the mucus in their throat, and that goes down into their lungs. And normally below the larynx, like you don't have pneumococcus or Haemophilus, do you? You don't have those bugs, but it's easy to aspirate a little bit of the mucus from the retropharynx, and that then you've got then virus in the lung and you've got bacteria in the lung. And so co-infection is much more common. And that's why it's really hard to withhold antibiotics from children who've got bronchiolitis, whereas in other countries, it's possible to say, well, this child's just got viral bronchiolitis and probably we don't need to give antibiotics. But here it's just harder because of the potential for co-infection, that's all, okay? Right. I wanted to just touch on the causes of lung hyperinflation. We've talked about that before, but let's just list the causes. What could cause such severe lung hyperinflation. You can see in this child, flattened hemidiaphragms, black lung fields, separated ribs. What can cause that? We've talked about bronchiolitis and we've talked about asthma. Anything else? So, yeah, good point, Hicks. Sometimes, yeah, can you explain that, Hicks? Very good point. That's right. The lung fields look black, don't they? What's the difference between a child with dehydrated lungs or with dehydration, the X-ray, and this X-ray, children with bronchiolitis or asthma? There is a difference, and you can make the distinction. What's the difference? Yeah, maybe not so much. But a child who's got dehydration won't have hyperinflation. They'll have black lungs, but not hyperinflation. So that's the way you make the distinction, right? Sometimes a child who's got hyperinflation will appear to have a small heart, won't they? Because their diaphragm gets pulled down, right? So therefore their mediastinum elongates. So therefore their heart seems to be narrower, right? And that will look a bit like a child who's got a small heart from dehydration. But a child who's got a small heart from dehydration won't have that hyperinflation. They won't have the increased number of ribs visible. So you can make it because of that. All right, but that's a good thought. Sometimes black lung fields can because of dehydration. That's not common, but it can occur. What else might cause hyperinflation like this? We've thought about bronchiolitis, asthma. There's a couple of other things. Yeah, obstruction. What other sort of obstruction? Yes. All right. Airway obstruction from a mass, that's true, yeah. Or from, so you're thinking about, remember when we think of obstruction in any setting, we think about outside the airway, in the wall of the airway, inside the airway, right? Same as a vessel, right? So you're thinking about a mass that might be outside the airway compressing on the airway, right? Like a mediastinal mass. What could be like inside the airway, in the lumen of the airway? A foreign body, yeah, good. So a foreign body, always think of a foreign body. And could that give you this sort of X-ray? It could do, especially if it was where? Fairly proximal. If it's proximal, if it's distal, like it's gone past the trachea, past the carina, down to the right main bronchus, then it's more likely that one of the lungs is going to be inflated, isn't it? Probably more likely like the right lung will be inflated with a ball valve obstruction, right? And the left lung might be collapsed, right? But if it was in the above the carina, then you might have both lungs hyperinflated. Yeah, good. So foreign body, always think about it. What else?
Croup.
Yeah, croup. So croup can give you that, although croup doesn't usually. And it's usually obstruction that's below the larynx that'll give you hyperinflation. All right. So obstruction above the larynx doesn't usually give you a hyperinflation, right? You don't see too many children with croup who've got hyperinflated lungs. If the obstruction goes below the larynx, like if they've got tracheomalacia or they've got a foreign body, right? Yeah. Anything else? So if you had some sort of a congenital obstruction like tracheomalacia, all right, and sometimes if you've got over distension of the lung because of a like lobar emphysema, right? Sometimes babies can have like congenital lobar emphysema where their lungs are congenitally abnormal and over distended. That's rare, but just think about congenital problems of the lungs or a foreign body or bronchiolitis or asthma. The last two being the most common, of course, bronchiolitis and asthma. All right. Yeah. Now, when we talked about this baby who's 13 months, we said that there might be some therapies, 13 months with bronchiolitis. How can we get a bit better idea of whether bronchodilators might work or not work? Can you think of any clues to whether bronchodilators might work or not work? It's a bit hard, but if this is not the first episode of wheezing they've had, if they've had recurrent wheezing, then you start to think that maybe they're developing into asthma. Does that make sense? So if they've had recurrent respiratory distress, they get better in between, but they get wheezing again. Then that makes it more likely that I'll try bronchodilators. But in most 13 months month-old babies who've got severe bronchiolitis, it's worth trying some bronchodilators. Now, the question is, how do you try them? Do you know how do you try them? You give some salbutamol. What do you do then? Yeah, you have to have a proper trial. And that means, I don't mean like a controlled trial or research. I mean, in that patient, you've got to be objectively observing certain things to see whether it's better or not better, all right? Because often we maybe try it once and it doesn't seem to work. You don't think the child's much better. Of course, it's not going to make them completely better, is it? Bronchodilators, even in a child with bad asthma, it sometimes takes 12 or 24 hours to work properly to completely resolve their asthma. And so you're looking for small signs that maybe it's made some objective difference, right? Their respiratory rate might come down, their degree of chest indrawing might be better, their saturation might come up, etc. You know, that sort of thing. So it's useful not to, when I try bronchodilators, I try not to change anything else during the time you're trying the bronchodilators. Just leave everything else the same, but record like what their degree of chest indrawing is, what their like tracheal tug, all those features of chest indrawing, their respiratory rate, their saturation, and then see what it is like afterwards, the amount of wheeze, etc. So you need to do like a controlled trial. If you find, I think it's always worth trying salbutamol. And if salbutamol works, then maybe some of the other bronchodilators might work. If salbutamol doesn't work, if the baby with bronchiolitis just has continued wheeze and crackles and respiratory distress, and salbutamol makes no objective difference, then I don't try the other things. All right. Usually I don't try aminophylline or adrenaline or steroids if the salbutamol doesn't work. But if salbutamol does work, then you can think about adding steroids or adding Atrovent or adding some other bronchodilator, right? Depending on how severe they are. All right. And there's a couple of bronchodilators that I wanted to, well, a couple of therapies for bronchiolitis that are not necessarily bronchodilators I wanted to talk a bit about. One is nebulized saline. Now, that's not a bronchodilator. It's not a bronchodilator, but it can be useful in some children with bronchiolitis. And there's been some studies done to suggest that it can be useful. So even if this child wasn't responsive to bronchodilators, you might still give some nebulized hypertonic saline to help secretion clearance. Don't want to overdo that, but there is evidence that it helps secretion clearance. Not only, this is a Cochrane review, like a systematic review of multiple trials suggesting it does help. And as I said, 28 trials, a huge number of trials have been done with hypertonic saline, not just normal saline, but hypertonic saline, because that can help clear the secretions better. There's been a couple of trials of normal saline, including Dr. Gordon Pukai's trial, which was very good here. 200 patients, nearly 200 patients with bronchiolitis under 2 years of age, and they either received nebulized normal saline or standard care. And those that got normal saline had reduced respiratory distress score at 4 hours, and they had improved oxygen saturation, and they had a higher safe discharge rate. That meant that after 4 hours, more were able to be discharged without bouncing back with worse respiratory distress. So there's some evidence that even using nebulized saline in children with bronchiolitis can be beneficial. A couple of doses of that can be helpful. That, again, I usually try salbutamol first and see if they're bronchodilator responsive. If they're over 9 months of age, under 9 months of age, it's not really worth trying salbutamol, right? There's another therapy that sometimes is useful, not in bronchiolitis, but in asthma, and that's magnesium. And there's a variety of reasons why magnesium can work, and magnesium has been shown to be quite effective in asthma, and it's been shown to be effective both if you give it intravenously, and also some people have given it in the UK, they give it also nebulized, right? And so maybe that's rarely done, but intravenous therapy with magnesium is often done. And these days in children, you don't do it for mild or moderate asthma, but when you see a child with severe asthma and they're bronchodilator responsive with salbutamol, but of course they're partially bronchodilator responsive, no one's completely bronchodilator responsive if they've got severe respiratory distress, then you want to think, well, what other therapies should I be adding now? And magnesium is one therapy that can be beneficial, all right? And the dose is 0.2 mils per kilo IV over 30 minutes. And if you can measure the magnesium level, that's helpful. And I usually try, the normal magnesium level is up to 1.2. And usually I try to push it up to about 1.5 and try to keep it at about that level in children who've got severe asthma. So that's very effective in asthma. It's not proven in bronchiolitis, so I don't use it in bronchiolitis, but in asthma, yes. There's lots of physiological reasons why magnesium might work as well. All right. So I just want to show you two X-rays of different children that also have hyperinflation. And remember we said you can see how black these lung fields are, can't you? The lung fields are black, the diaphragms are pushed down. Can you see even I'm not sure whether my pointer works, but yeah. You can see even this lung, this left lung, see how over distended it is. That's the size of the left lung, is way out here. Huh? What could this be due to? It could, yeah, well, it is obstruction, isn't it? It's either functional or mechanical obstruction, isn't it? Yeah. And most commonly with asthma, it's functional obstruction. And with bronchiolitis, it's both functional and mechanical, isn't it? Because you get bronchial edema and secretions and things. But it also could be if you had a foreign body that was where? Yeah, in the left main bronchus. If you had a foreign body in the left main bronchus causing a ball valve obstruction, then that could cause over distension of the left lung to that degree, for example, couldn't it? And what about this one? You can see, you can see this is the right lung, all right? Very over distended, isn't it? Markedly over distended, yeah? Okay, even the left lung is also over distended. Now, both of these children had RSV. They just had respiratory syncytial virus. So that tells you just how much RSV bronchiolitis can cause over distension of the lung. But when you see an X-ray like this, you've got to think, is that the only thing going on? Or could there be something else going on, such as congenital obstruction, such as a foreign body, or is it just severe asthma that needs bronchodilator therapy? Does that make sense? Yeah, okay. So a common problem, hyperinflation of the lungs, over distension of the lungs, gas trapping. We see it commonly, and it's just good to be thinking through it about the clinical signs and about the differential diagnosis, the pathophysiology that's going on, and what treatments might be effective. Okay. Now, I wanted to show you this child. This is the second case. This is a little bit different because the first child I showed you was acutely unwell. He'd had just 2 days of cough, fever, and respiratory distress. So you can start thinking this is an acute infection or an acute problem like acute asthma. But this was a 2-year-old girl who'd had 3 days of cough, fever, and respiratory distress. And she had severe respiratory distress with crackles, and she was very deeply cyanosed. And again, a very prolonged expiratory phase. But she also had a history of stridor every time she ran. So she's 2 and she could run around, but every time she ran around, she got stridor. Her mother was able to give that history very clearly. So this is not like the first child who had acute airflow obstruction. This is acute on chronic airflow obstruction. And the differential diagnosis of that will be quite different, yeah? It might overlap a bit, but it'll be quite different. And that's why the history is so important, trying to understand the differential diagnosis requires trying to understand the history in its detail. So what could cause acute on chronic or recurrent airflow obstruction? What things? Well, if any of the things we mentioned so far, could they cause it? So, yeah, laryngitis, it's usually acute though, isn't it? But what would cause like chronic laryngitis or chronic laryngeal? Good, laryngomalacia. Maybe the baby was born with laryngomalacia, and then this time, what could have happened? Like, you've got to put a story together. So she could have laryngomalacia. Exactly. She could have laryngomalacia, then she gets a viral infection, and then it goes to her lungs, and she's got like a viral. When you look at the X-ray, does it look like she's got some changes in the lung fields? We've been looking mostly at hyperinflated black lungs before, haven't we? And what has this child got? Then are they black? Are they hyperinflated? They're not, are they? They're actually, remember when you're thinking about a child who's got respiratory distress, you can divide it into two categories, many categories, but there's two. One is large lung volume diseases, and one is small lung volume diseases. All right. And we talked about the large lung volume disease. Do you get what I'm talking about? The large lung volume diseases are like conditions where you've got hyperinflation, such as asthma or bronchiolitis, inhaled foreign body, that sort of thing. And the small lung volume diseases are what? Why do you get? Yeah, good, pneumonia. Why in pneumonia do you get small lung volumes? Yeah. Yeah, consolidation, and you get like alveolar collapse, and you get areas of atelectasis. So the lungs are sort of collapsing down. They're not obstructed and gas trapped. They're collapsing down and inflamed, and you get atelectasis consolidation. That's right. And what other small lung volume diseases do you know of besides pneumonia? Newborn babies have a classic lung disease that's small lung volume. Sorry? No, meconium aspiration is not a small lung volume disease. It's often, why is it sometimes a large lung volume disease? Good, meconium plugs get into the airways and cause overdistension of the lung. Yeah, airflow obstruction. What's the other neonatal lung disease where you get small lung volumes?
Hyaline membrane disease.
Hyaline membrane disease, that's right, respiratory distress syndrome. And why is that? Why do you get small lung volumes with hyaline membrane disease?
Because the deficiency of surfactant.
Very good. You get a lack of surfactant, you get alveolar collapse. That's what you're seeing on the lungs of children with, preterm babies who've got hyaline membrane disease. You're seeing all this alveolar collapse. There's no air in the alveoli. That's why they look ground glass and sort of a bit whitish, isn't it? Eh? They're not completely, like the lungs not completely collapsed, but all the little alveoli are filled with fluid and collapsed. Yeah. Okay. So this child clearly has relatively small lung volumes, isn't it? If you count when you're counting the ribs, let's count the anterior ribs. 1, 2, 3, 4, 5, 6 at most. You can see just six ribs, whereas in the other ones, let's just go back, right? Let's try to count these ribs. 1, 2, 3, 4, 5, 6, 7, at least 7. Yeah. So even one rib makes a big difference to the expansion of the lung. All right. And so this child's got a smaller number of anterior ribs, maybe 1, 2, 3, 4, 5 at least, right, on this side. So 5 anterior ribs seen, but also there's patchy atelectasis throughout, isn't there? Yeah. And you can see some air bronchograms. So that suggests that there's some airways collapse, right? Consolidation. All right. So but going back to the clinical problem, we said she might be a baby who's got laryngomalacia with a lower respiratory infection. Yeah. Okay. So that's possible. What else could cause acute on chronic airway obstruction or acute on chronic airway problem? Laryngomalacia is one. What else? Sorry? Croup. Yeah, good. Croup. And croup could do it, although croup usually occurs with a viral infection, yeah. But there are a group of children that have what's called spasmodic croup. all right? And instead of having croup related to a viral infection, they have croup like asthma, all right? And they can get, just like children have exacerbations of asthma when they get exposed to a virus or an allergy, then there are other children that can have croup with spasmodic croup, and they have, yeah, so spasmodic croup could do it. Although this story is, remember, it's a history of stridor every time she runs, all right? And 2-year-olds are running around all the time, all right? So she's got stridor quite frequently. So what else could cause it? Well, when you hear a child's got respiratory distress and noisy breathing every time they run, what do you think about? The most common reason for that would probably be, we've talked about it, asthma. Children with asthma are classically like that. They have their episodes of asthma where they get a virus and they got severe wheezing. But if they have like some sort of background of chronic asthma, it's not so bad that they get severe respiratory distress when they're just sitting there or doing normal things. But when they run around, they've got a bit of airflow obstruction, so they cough. So that's a common exercise-induced asthma, is quite common. Exercise-related wheeze, quite common. So it could be asthma, and now she's got an acute lower respiratory infection. Or it could be laryngomalacia. You know, those things that you should be thinking about. Anything else that you could think of?
Epiglottitis.
Epiglottitis, yeah, epiglottitis is not usually a recurrent problem. It's usually severe and occurs only once. All right, so it wouldn't be like on my list. I don't think of cause of acute on chronic airway obstruction. Potentially, if a child had an inhaled foreign body, then they've got reduced exercise tolerance, and they might cough and wheeze every time they ran. And then because of the inhaled foreign body, then they can get a lower respiratory infection. So that could fit within inhaled foreign body, I suppose. And there's one other type of problem that I want you to think about that is uncommon, but can be a cause of this problem. When you look at this girl's chest x-ray, what do you also notice? So you can see that there looks like there's some acute lower respiratory infection. What about when you're looking at an x-ray, you should also look at also the cardiac shadow. Very good. What do you notice about the cardiac shadow?
Could there be a mediastinal mass?
Yes, yes. Good. Well done, Miss. It could be. It looks like there's some enlargement of the upper mediastinum. Hang on, I'm not showing you that. Yeah, it looks like there's a bit of fullness here, isn't there? Now, a bit of fullness. It doesn't quite look like a mediastinal mass is usually a bit more circumscribed, isn't it? What can cause a mediastinal mass, Mispa? Sorry?
The upper airway and large vessels, the structures there, or lymph nodes.
Yeah, often lymph nodes, and usually sometimes they can look a bit hazy like this, and sometimes they can look quite circumscribed. You can actually see the lymph nodes. What's another thing that can cause a mediastinal? Good, yeah. The mediastinal masses typically, especially if they're midline, either arise from paratracheal lymph nodes, all right, or para-aortic lymph nodes, or they arise from the thymus, don't they? So lymph node enlargement from TB or from lymphoma, or thymic masses from T-cell lymphoma or T-cell leukemia. It doesn't quite look like that, does it? It's a bit more hazy, all right? What else should you think about? Any other thoughts?
Sometimes there's air in the mediastinum, like pneumomediastinum.
That's true. Sometimes there's air in the mediastinum, but actually this looks white rather than black. We'll get onto the air in the mediastinum, but this looks white rather than black. All right, we'll move on. What about a cardiac problem? Could this be a cardiac problem? Can you think of a cardiac problem that could do this?
No.
Sorry? Oh, what's that? A coarctation, yeah, not typically, but okay. All right, so it's possible it could be any of these things. This I want to show you now. Whoops. I want to show you now her vital signs. Whoever's still got their could you mute your sure. Who's still got their okay, thank you. I want to show you her vital signs monitor now because you're starting to look at vital signs monitors and ECG monitors and plethysmographic tracers and starting to, I think, learn about vital signs monitors. But this was this girl's vital signs monitor, right? And I'm going to show you, I hope I can show you. Oh, yeah. I can show you. Yeah. Just watch it. Oops, no. Okay, this is can you all see this? The vital signs monitor moving, yeah? Well, the arrows give it away, but I wanted you to, let me show you again. I think this is a very, very good example, and we see it quite a lot, but we don't recognize it. What's happening? What can you see? Okay, there's two things. One is the just look for the purposes of what we have at our disposal, usually in terms of vital signs, just look at the saturation trace. This is the arterial trace, but that's an arterial line. This is the saturation trace, right? And it tells the same story, right? What's happening? Sometimes we see like a fluctuation and we think it's just an artifact, the child's moving or something. This is not because of that. What is that? What is happening? Yeah, good. Yeah. It's the pulse pressure is fluctuating depending on what? Based on what? Yeah, it's not this on the what?
Inspiration and expiration, the pulsus
Very good.
paradoxus.
Very good. Yeah, well done. It's based on the respiratory cycle, all right? Based on the respiratory cycle. So on inspiration, the heart rate is increasing and the pulse volume is increasing. On expiration, it's decreasing, all right? Does that make sense? And you'll see that if you're doing saturation measurements on children who've got acute lung injury of any sort, especially airflow obstruction, then you watch for this sign. It's an important sign because it tells you something of the severity of the airflow obstruction. Just watch it once more. Right? Depending on whether it's inspiration or expiration, the plethysmographic trace is fluctuating, right? Speeding up on inspiration, slowing down on expiration. And why is it speeding up on inspiration? Or why is the pulse volume higher on inspiration? When you're inspiring, what do? You expand your lung fields and you therefore allow more blood to flow into the heart, right? There's more filling of the ventricle. So therefore the stroke volume is larger. So therefore the pulse volume becomes stronger. Does that make sense? Right? And when you expire, when we normally expire, do we get this fluctuation? No, we don't. Why is that? Very good. Because when we expire normally, if you've got normal lungs, when you're expiring, you're not increasing your intrathoracic pressure. It's just normal elastic recoil of the lungs. But remember what I said about right early on, when you've got a child who's got wheeze and expiratory airflow obstruction, what do they have to do to breathe out? They have to force it out. That's why they have prolonged expiratory phase. They have to increase their intrathoracic pressure to breathe out. And so therefore their venous return to their heart decreases. Therefore the filling of their ventricle decreases, their stroke volume decreases, and their pulse volume decreases, right? And so this is a good sign of the severity of airflow obstruction, right? Or some other reason why the stroke volume is changing with the respiratory cycle. Why else might the stroke volume change with the respiratory cycle? Now we're getting into more complicated areas. Why else can you think of another condition? So this can occur with asthma, severe asthma, or severe bronchiolitis, or any cause of like severe airflow obstruction. But can you think of another type of condition where the stroke volume might change with the respiratory cycle? So very good, a pericardial effusion. If you see this in a child who's got a pericardial effusion, then they've got tamponade, haven't they? Because their stroke volume is changing with their respiratory cycle. And it's the same mechanism in a way. It's just that they've got fluid surrounding their heart, so their stroke, their ventricle can't relax that much. And so the effect of breathing out means the intrathoracic pressure is higher, and that just puts a bit more pressure on their ventricle so it can't fill. Does that make sense? It's just this, it's a similar mechanism, but just slightly different, okay, to like severe airflow obstruction. All right. Okay. I won't go through this, but I think I've explained it. It's like a form of pulsus paradoxus, all right? And you can see it with cardiac tamponade. You can see it with upper airway obstruction of a severe degree. And you can see it with other obstructive lung diseases like it with asthma, all right? We've talked about why that is. And, but from now on, when you're looking at a plethysmographic trace, the saturation trace, like, of course, you're looking at the actual saturation, but also if you see this fluctuation, then think, is there obstruction? And if it's obstruction, is it lower airways or upper airways? Or could it be that they've got tamponade, right? There can be a few other reasons why you might see this. Can you think of anything else? So you said a pericardial effusion might cause tamponade, but is there anything else that might cause tamponade, causing this? If you've got a big tension pneumothorax, yeah, tension pneumothorax will do it because that causes tamponade on the heart, therefore it puts pressure on ventricular filling. That's the main thing, yeah? Okay, right. Okay, a bit like this. Now, I won't go through the possible causes, but I guess we've gone through those. It could be upper or lower airways obstruction, but this was a child who had both acute and chronic, and she ended up having this problem. So a cardiac problem, all right? And rarely you'll see, can you think of a cardiac problem that might do this, cause obstruction that might look like laryngomalacia? The cardiac problem is broadly speaking what's called a vascular ring. Have you heard of a vascular ring? A vascular ring is anything where the blood vessels surround the trachea, right? Normally you've got the aortic arch just going over like that, but sometimes children are born with like a double aortic arch, and one side goes in front of the trachea and one side goes behind the trachea. Some babies are born with what's called a pulmonary artery sling, where the pulmonary artery winds around the trachea, right? It's just a developmental anomaly like a VSD or like an ASD, and it can cause a vascular ring. Just means there's some sort of ring of a blood vessel around the trachea. And this girl, I won't go through it in too much detail, but this girl had what's called a pulmonary artery sling. And I think you can see this. This is a CT scan with contrast, and this is a right ventricle. This is a pulmonary artery. It looks large, and you can see it winding around the trachea. The trachea is black. It's winding around the trachea and causing that obstruction. And that's why she had that stridor every time she ran, because she's got tracheal obstruction. And that's why she was susceptible to viral infection and got pneumonia, right? So she had a pulmonary artery sling. It doesn't, yeah, that's all. Okay. All right, don't worry about that too much. Now, how are we going for time? Yeah, we might do one more, eh? One more case. All right, I've got two more, but we'll just do one more. And because you raised this before, this was a a 4-month-old boy who had failure to thrive and respiratory distress. So he had failure to thrive, meaning he had chronic malnutrition, right? And he had presented with severe respiratory distress. And on examination, he had all the signs of respiratory distress. He had fever and tachypnea, and he had oxygen saturation of 65 to 70% on air. His temperature was 38.8, respiratory rate 70, heart rate 180. That's all we knew clinically at that time. This was his full blood count, all right? And this was his X-ray. Can someone describe the X-ray?
What's obvious to me is that the trees, the lungs are hyperinflated, and there's like tracks of air going up the mediastinum into the underneath the neck as well. Yeah.
Very good, Miss Burr. That's exactly right. This is, so what do you call this, Miss Burr? It's a pneumomediastinum, isn't it? We get used to pneumothorax, right? But you can have air in other places. We saw a child this morning who had lots of air in the subcutaneous tissue. So subcutaneous emphysema, a pneumothorax, a pneumomediastinum, which just means air in the mediastinum. And the last one is sometimes you can get, when you get air in the mediastinum, sometimes you can get it around the heart, which is called a pneumopericardium. Good. So when you're thinking of like air where it shouldn't be, all right, the commonest thing is the pneumothorax, but pneumomediastinum is also quite common. Subcutaneous emphysema. Do you think this child would have subcutaneous emphysema? Yes, because you can see it up in the tissue planes of the neck, right? And also look at the heart shadow. Sometimes you can see air, and you can actually see the pericardium outlined as a line with air between the pericardium and the heart, right? So this child's got a severe respiratory distress from a severe pneumomediastinum, isn't it? Yeah. So the key features on the clinical history, obviously the severe desaturation, the fever the child's got. Perhaps if you look at the full blood count, the white cell count looks okay, doesn't it? 6,000 is okay. 5,800 neutrophils, that's still okay. The lymphocytes are very low, right? Platelet count, that's a little bit low, but not too low, Hemoglobin is okay, all right? And then when you look at the X-ray, then all of these other areas that Misbah pointed out, where you've got air tracking up in the tissue planes of the neck, where you've got air in the mediastinum here, and air coming down here. You don't usually see this air line of air. There's extensive pneumomediastinum, all right? And so what could cause this? When you see a pneumomediastinum, what do you think about? Well, you guys saw a child with a pneumothorax and subcutaneous emphysema. They're all rather similar in terms of the etiology. So what did that child have? Yeah, he had staph pneumonia, wasn't it? And the reason why you sometimes get air leak in staph pneumonia is because of an abscess an abscess or a pneumatoceal, isn't it? A pneumatoceal is a bit different to an abscess, isn't it? An abscess is pus filled, and a pneumatoceal, what is a pneumatoceal? It's air, but normally we have air in our alveoli, and they're tiny, microscopic, but this is an air where? Sorry, in the lung parenchyma, yeah. but it's an area where there's, remember, staph pneumonia is a necrotizing pneumonia, right? So sometimes there's pneumococcal pneumonia. It's necrotizing pneumonia, which, what does that mean? Tissue breakdown, isn't it? There's tissue breakdown, yeah? So when you've got tissue breakdown and you've got the alveoli breaking down because they're being like inflamed and being eroded away by the staph, then you can sometimes get pneumatoceles. And often pneumatoceles occur at a time when the lungs are starting to heal. They don't usually occur at the time of presentation. They might occur 4 to 7 days later, all right? And so sometimes they'll burst and cause that air leak, a pneumothorax, a pneumomediastinum, subcutaneous emphysema, perhaps, yeah? All right. Can you think of anything else that might cause a pneumomediastinum? We thought of staph pneumonia. What else? Okay, we'll keep going. Well, what about this lymphocyte count? Is this common to have a lymphocyte count that low? It's actually quite common in children who've got acute infections. You often see the lymphocytes being that low. Just to give you an idea of the normal lymphocytes, these are the normal lymphocytes for age. So up to 2 years of age, it should be 3,000. Between 2 and 6 years of age should be 2,000. So it varies according to age. Doesn't go up, it comes down. The normal values are more than 3,000 up to 2 years of age. We often see in infants who've got acute infections, their lymphocyte count will be low, but it doesn't stay low, all right? And so whenever you see a child who's got lymphopenia like this, it's probably due to an acute infection. But you've got to think, if the child's got chronic malnutrition or failure to thrive, have they got some chronic underlying immune problem, all right? So what I usually do is I accept that it'll be low to start with, and then I repeat it at 7 days. And if it's still low at 7 days, then you need to investigate them for immunodeficiency of some sort. Okay, does that make sense? Yeah. Usually lymphopenia related to a viral infection or a bacterial pneumonia will have resolved by 7 days. Okay, so I wouldn't get too excited about that at the time of presentation, but you need to think about this child's got failure to thrive and chronic diarrhea and lymphopenia and a pneumomediastinum. Does that add up to anything to you? What would you be worried about? Yeah, immunosuppression, yeah. And if the child had immunosuppression, what might be the condition that causes a pneumomediastinum? Sorry? PJP. Yes, that's right. Pneumocystis pneumonia. That's right. Yeah. So this was a child who had pneumocystis pneumonia. So a child with failure to thrive, chronic diarrhea, lymphopenia, and this is pneumocystis pneumonia with air leak. All right. There are a number of different causes of air leak. And again, I won't go through all of these. We've talked about most of them. Sometimes you can get it with asthma or a foreign body or bronchiolitis. You know, with a heavy bout of repeated coughing, we've seen it with RSV. So it doesn't always relate to pneumocystis or something, or staph pneumonia. Sometimes you can see it with tuberculosis. And sometimes you'll see it because the air is not leaking from the lungs. The air is leaking from the esophagus or the larynx. All right. And so you can see it in esophageal perforation, or you can see it in laryngeal trauma. So when you see air leak, you've got to think, where is the air leaking from? All right. But in this case, and in this case, you can see this is a different child who also had pneumocystis pneumonia and failure to thrive and lymphopenia. And you can see that there's, what is there here? Not a pneumomediastinum, but there's pneumothoraces. And when you see, this is pneumothoraces, but they look a bit different. What is it about the pneumothoraces that look a bit different? What can you see? You can see the outline of the lung, can't you? The lung is clearly outlined. It looks like there's air surrounding the lung, but the lung's clearly outlined. What does that tell you about the lungs? it tells you that the lungs are so consolidated, they're not collapsing. All right. If the lungs were just full of air, if they were normal lungs and you get a pneumothorax, then usually you get the lung collapsing. But if you see the lungs being outlined like this, then it tells you there's consolidation there. And so if you've got pneumocystis, your lungs are very consolidated usually. All right. So the lungs don't collapse. You also see it with babies who've got hyaline membrane disease, don't you? You see their pneumothoraces, but they're just rims of air outlining the lungs. And why is that? Because those lungs with a baby who's got hyaline membrane disease and are non-compliant lungs. They won't collapse very easily. Okay. All right. So if you see air leak and in a child with failure to thrive, then think about this could be immune deficiency. And it could be congenital or acquired immune deficiency like HIV or some form of congenital immunodeficiency. This was just to show you two more x-rays of children who had air leak. This was just a child who had bad asthma, all right? Or just bad asthma. And of course, it's more than asthma because the child's got pneumothoraces, got severe pneumomediastinum, extensive subcutaneous emphysema, even up to the head and neck, you can see. Okay, I'm not sure whether you... Can you see the slides? I'll just try to share the screen. Okay, yeah, this is the last slide anyway. This is a child who had very severe asthma with severe air leak. And the last picture of air leak I want to show you is a child who had tetanus and air leak. And you can see the same thing again, subcutaneous emphysema going up into the neck and a pneumomediastinum. And also, if you look at this lung field, looks black compared with this one, all right? And you can start to think about whether there could be a pneumothorax on the right as well, all right? So, and the reason why a child with tetanus might have air leak, can anyone think? Why? When you've got tetanus, you've got muscle spasms, isn't it? And it can be limb spasms, but it would also be chest wall. All right. If you're frequently your chest wall's going into spasm, then sometimes that can cause an air leak. All right. So that's what happened with this child, a severe air leak related to that. Okay. All right. Well, that's all I wanted to say today anyway. So I think we'll stop. I've stopped sharing the screen. I might just try to stop recording.